Good afternoon. We will begin right on time. It's a pleasure to introduce the next presentation, Fernanda Ribeiro, for the next 30 minutes. First, a quick introduction. Ms. Ribeiro received a bachelor degree in Brasilia for physical therapy, and then after a health science degree in Brasilia, she has a Master of Science in Health Sciences, as a PhD candidate in experimental medicine at Laval University. Currently, she's an assistant professor at the University of Quebec at Chicoutimi, UQAC, primarily teaching cardiorespiratory physiology and rehabilitation. She has also started research collaborations in the Groupe de Recherche Interdisciplinaire sur la Recherche Neuromuscular de GRIM, focusing on cardiorespiratory functions during exercises in patients with myotonic dystrophy type 1 DM1. Her research interests include the integration between cardiorespiratory impairments and exercise capacity in neuromuscular diseases and in multimorbidity. She has published articles in peer-reviewed journals on locomotor muscles oxygenation and functioning evaluation in patients with chronic respiratory diseases, including some collaborations relating to muscle function and other diseases as cancer and pulmonary hypertension. We could continue on, but I will let you pursue. She will be presenting in French, slides are in English, and there will be translation.
Présentation.
Merci beaucoup. C'est une présentation assez...
Thank you. I changed my mind to speak in French. I think most of people here are French speakers, and also to help those who are not speaking French. Slides will be presented in English. As you've seen from my background, what is interesting me is when there's a cardiorespiratory problem, whether that person has for example, it's a neuromuscular disease that will cause cardiorespiratory problems. After I arrived in Chicoutimi, I quickly got to know the GRIM research group, and I started already to identify that maybe we could take a closer look at what is going on with regard to DM1 patients with regard to their cardiorespiratory capacities. So my presentation will be focused on impairments, cardiorespiratory impairments in MD1, and then the relevance of cardiorespiratory response to effort, more general, and then to MD1. Also, what is the relevance of studying desaturation, exercise-induced oxygen desaturation, and MD1, and what are perspectives in research and clinical care. I think this is more open to more of a discussion that we can have between research and clinical practice. We know that in MD1, about 80% of patients present cardiac manifestations, including arrhythmias and conduction impairments. These are the most common. Occasionally, can be cardiomyopathies. Contrary to Duchenne, having a lot in MD1, cardiomyopathies are occasional. But because of this, sudden death is a main cause of mortality for these patients. How to manage? Well, through ECG and other tests. Occasionally, for the younger patients, that is recommended. So stress tests to exercise are recommended. Respiratory function, we know it's a cause of death also. The main impairments that are found are reduction of force, vital capacity, inspiratory and expiratory muscle pressures, and these muscles, these respiratory muscles, and also a reduction of peak cuff flow, the main measure to identify airways protection, for example, to get rid of mucus. When talking about respiratory function, we see that there are guidelines already that have been developed for these people and how we will manage these patients, how often they will be reassessed. For example, if they are asymptomatic or symptomatic, something that that really draws my attention for symptomatic versus asymptomatic for some that have impairments such as apathy. It's how it's defined currently, and it will be really focused on the vital, cardiac vital functions, or force vital cardiac. What about lung volumes and ventilatory responses during exercise? During my research, I looked into response to exercise for those who have chronic obstructive pulmonary diseases. And if I make an analogy for these people with respiratory problems, it's important to see how volumes react not only at rest, but also during exercise. If we see here, this is a normal response to exercise. We only look into the current volume. When breathing faster during effort, we take slightly deeper breath, and we can still gain a little more air. That is the respiratory effort during exercise. When there's an obstructive problem, current volumes will greatly be reduced and will be much closer to the total pulmonary capacity, as if lungs were already too inflated. The problem in this is that we are starting to ask ourselves then, and just going back if I can, will patients have this type or that type of response? When we cannot expand properly the torso, we will see this response from somebody who has a pulmonary disease. So then we'll be asking ourselves why these patients with MD1 could be at risk of having a response, a ventilatory response that is inappropriate. Two things in literature, one better described than the other. Respiratory muscles weakness, which is progressive, will make it so we cannot increase tidal volume during exercise, during continuous exercise, meaning we cannot keep up with an intensive exercise because of a lack of tidal volume. And also, one article published this evidence here. The reduced ventilatory response to CO2. There's a certain insensitivity to CO2. So during the blood flow, CO2 increases during exercise, and that is the main sign to increase ventilation for the brain. However, there's current evidence that's for MD1 patients that does not happen for some of them, meaning that they need a CO2 level that is much too high, or the response arrives too late. This is a certain insensitivity that creates a inappropriate response during effort. Now, if we go back to the first year of university, that is physiology, we will be reminded. Let's keep in mind the picture in the middle here. When there is inappropriate ventilation, we might have hypoxemia. Why? Well, because the blood flow will be much too high for blood cells that cannot get rid of the quantity produced, the CO2 that is produced. What we'll see then is a base of impaired alveolar ventilation. The way I understand MD1 is that there are arrhythmia and conduction problems that will disrupt heart rate during exercise, and also having impaired alveolar ventilation due to weak lung muscles or respiratory muscles, leading to reduced ventilation. If there is not enough blood for ventilation, well, there's a risk for hypoxemia, meaning a low level of oxygen in the blood. When we think about disease management, it is not always during exercise and rarely during exercise that these patients are assessed. There's usually a rest ECG, and because the technique oftentimes demands that it be at rest, echocardiogram, lung function test, and then arterial blood gases. This is only the picture at rest. If we all measure everything at rest, why do we know what will happen if alveolar ventilation is required to increase as in exercise? We will not have this response. And this is where I started to think, if these patients have a problem increasing alveolar ventilation, such as other patients I had seen previously, like those have a pulmonary fibrosis, well, the cause is different, but the effect is the same. They cannot increase the quantity of air in alveoles. So I thought about how can I take a simple way to measure this response. The simplest way that I found in a clinical setting, I wanted to have a clinical context. It's a 6-minute walk test. This is already a test that is considered feasible, reliable, and sensitive to clinical changes in DM1 population. This test will also adequately represent daily living activities of patients. And this is why it's called a functional exercise capacity test rather than aerobic or maximum capacity test. The difference is the total distance. That's the main result. But we can also add heart rate response and O2 saturation. I wanted to mention I have no conflict of interest with these companies, but now we have devices that can record that are not so sensitive to movement, that were designed for walking tests, meaning we can continuously monitor saturation. If saturation is reduced, that is already a sign for us that oxygenation is inappropriate and the response is inappropriate. The name is exercise-induced desaturation. There's already a prognostic value for several respiratory diseases, a few cardiac or heart diseases such as heart deficiency. What is worrying me, however, is literature descriptions of hypoxemia, arterial intermittent problems, meaning it can be a low and then recovering, then go low and then recover. This is known for healthy individuals, for example, going to altitude, and also for chronic cardiorespiratory patients. It mentions that it can affect cardiovascular regulation, especially blood pressure. And if we think about DM1, while they are already, or MD1, while they are already sensitive, that would be very problematic. The skeletal muscle function, so far I have studied patients who will, for example, be more fatigued when they have intermittent hypoxemia, and also cognitive problems, because lack of oxygen affects all organs, meaning it can also affect the brain depending on the severity, the duration of these episodes. I've decided to study if this desaturation, this exercise-induced desaturation, is observable during the 6-minute walking test. From the longitudinal follow-up study at the GRIM, we looked into a cross-sectional study of 69 people. I'll gloss over this. Flatline measurements. We then adopted 2 desaturation criteria. I look at the 88% threshold. From preliminary results is that yes, a few patients behave like this during the rest rate. We see that there is a reduction of saturation. That is not normal. That means that the cardiovascular system cannot give an appropriate response. Most of our current patients are men. We only looked at late adult and adult phenotypes. Their pulmonary function is what is considered average, except for respiratory pressure, which reflects the muscle problems. We also have patients who have a normal rate and can keep a good percentage without going below 90%, and some who are very limited and will have an important saturation. The main results we have currently is that 25% of these patients with valid data, 59 of them, so 25% of them have a detectable desaturation during a 6-minute walking test. The importance of this is that, as far as I know, the only studies that will look into intermittent desaturation are those that are done during sleep, but none have been conducted during exercise conditions. Also, the effort of a walking test is auto-selected, so sub-maximal. It is not a very intense effort, but it can still induce a hypoxemia for these patients. I'm asking, maybe these patients are also experiencing this during current or daily conditions, like going up a staircase. Learn lessons with my patients in OPOC. When exercise-induced oxygen desaturation is present, we have a higher mortality rate, higher decline of pulmonary function, and higher loss of lean mass. Is this also happening with MD1 patients? I then ask myself, is functional exercise capacity lower when EID is present? Well, the current conclusion is that no, we are lacking statistic power here, but in red, with desaturation, we'll have a lower walking average during a walking test, but we'll find as many desaturated patients in high distance, and also as many non-desaturated and desaturated with a very low walking distance. The message here, and I'll just skip this, I'll skip the association between walking and respiratory disease. The takeaway message here is that a normal or a high distance in this walking test will not ensure that there is no desaturation. It is possible that it could be present. Then we looked at, is there an influence from basic pulmonary function at rest? I didn't find any association with this. However, we find that patients desaturating have, on average, a lower CVF or a lower capacity for those, and mentioning that yes, already a compromised function can have an effect on the walking test, and it's important exactly because of management. These patients desaturating will be found here in a management that is already requiring more monitoring. If we think about respiratory muscles, only for inspiratory muscles it happen, and also a little diffusion problem because of repeated pneumonia or the presence of an associated pulmonary disease or chronic disease. But we didn't find a difference in proportion from those having a adult versus a late adult phenotypes. A little bit more for adult phenotypes, but not significantly different. Maybe it's a sample size problem here. I would like to conclude with key takeaway messages, which is exercise may unveil or reveal cardiorespiratory impairments that are not detectable at rest. These patients that we assessed, well, the saturation was normal or higher than 90%. Most of them, 95%, very normal. However, during submaximal exercise, a non-intense exercise, there will be desaturation. EID will then be easily detectable by a field test, such as a 6-minute walking test. That's why I wrote to be continued, because we can start to understand what are the determinants of EID, the determinants of the occurrence of EID. Is there prognostic values for these patients? We don't know so far. And is there a role during exercise prescription, training, and muscle responses? Because we've seen by another study of the group that patients can respond to training, but do they respond as well if they're desaturating during exercise? Could it be an index of safety also, maybe security for these patients when training? I wanted to conclude by thanking of the GRIM team, especially these 3 people here who greatly helped in the study. Without them, it would have been possible to undertake this study, and also to all of the organizations that directly or indirectly contributed to this work. I'm open to any questions and suggestions. Thank you. José Rochelle, pediatric doctor, and this is Sherbrooke. And are there studies that looked into the effect of physical exercise on cardiac for neuromuscular children with neuromuscular diseases? Answer: children, I don't know. For adult phenotypes, there's a 2012 study that saw the variability of heart rate, but it didn't conclude to any effect. Maybe somebody looked into this more than me, but there was a variability of heart rate, which is somewhat expected. However, there was no beneficial effect in exercise. I think it's the way that exercise is prescribed that can play a role. Thank you, Fernanda, for this great presentation. It was very clear. I was wondering, we have more and more studies saying that exercise is safe for people with MD1, and who are prescribing exercise to maintain capacities. Now, knowing that desaturation happens with exercise, and it could be a contraindication factor that we offer, what indicators would be best to know what would be the contraindication in that case? Well, for your answer, well, I don't want to give you a cold shower, but that's how this idea was born. I was doing a lot of discussions with Elise Duchesne, my colleague at the UCAC, and we were wondering because she saw the muscle biological side, and I was always thinking about heart and lungs. And that the exact fruit of this discussion, if they desaturate, will it be the same? Will we prevent them from doing certain things? Will we do differently? So I don't have an answer currently. This assessment for exercise and neuromuscular diseases should be more in our minds because there's a limitation in the response when they cannot increase long volume during exercise as required. That is the obstacle to exercise, and that would also can be endangering because desaturating at 90% or 80% is a danger for a heart attack, or that's I forgot a second question, sorry. I was wondering, as an indicator for contraindication for forced vital strength, maybe forced vital capacity is used for all diseases. So when it is lower than 60%, patients already have sleep disorders, hypoventilation. Lower than 40%, patients even do hypoventilation during the day, meaning they retain CO2 in their blood. So it's always done, basically, but I don't think that is the best index for prescribing or not exercise. Do you have an idea what would be better indexes? I think it's a matter of finding this determinant to link forced vital capacity and saturation. Well, I'm just guessing currently. Thank you. Just piggybacking off my first question and this question. The ICPQ, that's where I studied, yes. That's a great team that's working with patients with cardiac or pulmonary diseases, talking about people desaturating at minimal effort and with cardiac and respiratory rehabilitation, they can improve their capacity. So hearing that the fact that there's a desaturation, will it really be harmful? Maybe, but can we readapt it to bring it to a higher level, just as those that have a heart or respiratory disease? So in the first step you said okay, but the second step will be, can we do rehab? So before saying that exercise is contraindicated, we need to say, well, let's get more information on harmful effects, and then what would be the next step for research? Can we improve their heart and respiratory capacities? Yeah, I studied at ICPQ, so yes, the question is, for patients with heart deficiencies and chronic respiratory diseases, the improvements that we see in exercise does not show improvement for respiratory function. Sometimes better heart functions if cardiac is already advanced and very little. But what we see in the improvement and capacity of these patients is because of the improvement of muscle capacity to use available oxygen. In the case of MPOC, it was one of the subject of my thesis. We give oxygen to these people while they do efforts for people with COPD, rather. So to see the response with muscles, to see if so the physiopathology is different. Also, patients with neuromuscular diseases will keep losing this ventilatory function, meaning that there can be an improvement, yes, but it will always be an obstacle because of the progression of the disease. That's a research question. Yes, exactly. Right. Thank you.